हेलो गुड इवनिंग मेरे बच्चों. You are once again welcome to NEET PG live daily. As per daily routine, on this NEET PG live daily we discuss some topic related to pharmacology, because I'm a pharmacologist. That is quite understandable. And last time I discussed hypolipidemic drug, but this chapter is little lengthy, this topic is little lengthy, and I wanted to clarify each and everything right from the lipoprotein metabolism, because that took some time, because without understanding that, it is difficult to understand the drugs, how exactly drugs are actually affording clinical improvement in these disorders. So today in this series I'm here with lecture 2. So we'll discuss about newer drugs that are last time only statins were discussed. Today we will be discussing other drugs that are related to associated with reduction in lipoproteins. For those who are attending this platform for the first time on YouTube, any classes or new entrant on this platform, I would like to introduce myself that I am Dr. Pramod Sharma. I am a super specialty in clinical pharmacology, and I have done my MD and DM both from PGI Chandigarh. Guys, once again I am reminding you about importance of this app, Telegram app, which is kind of messenger app, as we use this WhatsApp and all, similar to that. This Telegram app is a Unacademy has actually created a group on this Telegram app, and this you should join this group, because this group, the Unacademy as well as the educator, keep sharing the schedule of their classes, the topic and the time and all that. So you will be having advanced information about all these classes and all. So this is always good for you, because you guys are also be busy in preparing for your exams and all. Must be having your own timetable. You have allocated a particular time for particular subject and all that. Time for rest, time for other activities, and time for studies and all that. So you can always make a change in that, and if you find some topic which are of interest for you, or you like some educator very much, you don't want to miss any class of that particular educator, you can always take out time from your own busy schedule to watch these lessons live. So join this group, and further if you click this group, this link will take you to the Unacademy NEET PG live site on the YouTube. So that is also a good point, and further you can only receive message, but you cannot send message to us, because it is one-way traffic only. But that is good enough for you, because you will be having all the information about the daily schedule of the classes. I don't know whether you are aware of, many of you must be aware of this Unacademy learning app, because this is an app where you have free classes in the form of special classes. So if you do not have this app, I would rather recommend you to get it as early as possible. And in this app you will have opportunity to attend these classes. These are also absolutely free, no charges recovered for attending these classes, but you need to make your account on this Unacademy learning app, and this is available for both Android operating system as well as iOS. So you can download and install as per your need, whatever your device actually support. This could be Android or iOS system. So this special classes, the classes are absolutely free, but the advantage over these YouTube classes is these classes are you have ample opportunity to ask questions. That is the big thing, like that is not available in this YouTube platform. But here you can always ask a question. You can interrupt educator in between if it is possible, time permits, then the educator can always take up your questions or queries and can resolve them then and there. And so this is one of the thing where actually interaction part has been added, and the interface of this particular platform is absolutely different. You will have a different feel once you shift from this YouTube to this platform. It is not that once you shift to this platform you will lose, you cannot watch classes on YouTube. You can watch at both the places, but I'm telling you about the experience you might have after attending these classes. So this is always good. And one important thing I would like to tell you is, suppose I take class on YouTube, I take class on this Unacademy app, that is special classes. I take NEET PG plus classes which are actually subscription based. So I'm available everywhere, so you can follow me if you like my lectures and all that. You can follow me at all the places, but plus is a paid platform, so for that you need to subscribe and then only you can attend my classes. And but it on this Unacademy learning app, if you follow a particular educator, you can always send direct messages to him or her related to your queries, academic queries and all that, and those will be answered or replied back depending upon the educator, how early an educator respond to your queries. But as far as I am concerned, I would definitely give it a very I'm keen in giving quick reply, and very I like those students who are very inquisitive, ask something related to the subjects and all that. So I also enjoy answering such queries and all. So don't if you have not downloaded it, if you do not know about it, please go back home and download this as early as possible. And not only you tell your friends also, so that they can also take full advantage of this free service. For those who actually want something more than these free facilities which are being made available to the students by Unacademy, but they want something extra for them, the Unacademy has a provision for that as well, and that is in the form of NEET PG Plus platform, which is subscription based service. You can only join that platform once you pay for it, and this payment is the fee which is being charged. I think it's not hefty, it is just a small petty amount that I don't think would be a problem. I think so that shouldn't be a problem to anyone to pay this petty amount to join this platform. And this Unacademy NEET PG Plus, which is a customized platform for those who actually want something more than what is available free or at different platforms. So this subscription is available for 24 months and 12 months, and we definitely recommend to the subscriber 2-year subscription. But many subscribers find it that why one should subscribe for 24 months. Maybe I get this time, I crack or clear the exams this time only. So that way 12-month option has also been kept. This 24 months maybe for them who are still in the final year and they start their coaching from there only, and they can buy it for 24 months. But 12 months is also good enough because this much time is needed, because syllabus is too much, very well. And during this period, this much of time, I think you will be exposed to almost every educator of each specialty. So that is always good for you, because you will not miss any educator in any specialty. And moreover, during this time period, there could be many special courses which will be launched by these educators on this platform. So you can attend those as many as possible. That will definitely make you score better in your exams, because these courses are need based or according to the type of exam you are appearing for. So there are customization of these courses according to the need of the learners. But this subscription, as I said, is on paid basis, so you can use this referral code, because this referral code, if you like my style of teaching and all that, and you're influenced by my teaching capabilities, you can use my code, and this will avail you 10% instant discount on the amount that is to be paid. For example, for 12 months the charges are 22,500, and if you apply 10% discount, so this hardly becomes near about 20,000. So that's not a bad deal. I think there could be nothing better than this. And for 2 years, just by increasing or giving 25% extra, you can double your subscription period, that is up to 2 years. And payment can be made by different mode of online payments and all that can be done through that. And why this NEET PG Plus is a paid platform? Because it has certain facilities which other platforms are lacking, and that is the reason why this actually charges some amount for being member of this special platform. And see, the live classes which are conducted on Plus, similar classes are conducted everywhere, but the difference is that you have ample opportunity and lot of cross interaction between the educator and learner is a common thing at NEET PG Plus, because the number of learners are in fact or it's quite obvious that once it is a paid service, then the number of the subscribers will be less, the number of learners will be less. So the educators also have enough time and can give personalized attention to each and every learner, and can always help them do better in their exam, and also is very well aware of the strength and weaknesses of the learners, so can focus individually to work on the weakness or special weak areas of certain learners. So that is the advantage. You get a kind of privileged attention from the educator, and you actually, I said the number of students are less, so there could be quite frequent interruption in terms of asking queries, doubts and all that. So that actually keeps the class very interactive, and that is good for healthy communication should be there between the learner and the educator, because without real-time interaction between two, I think invalid or means reduces the effectiveness of any learning process. So this is important and good also. And there are facilities for live polls, leaderboard, and there are test series. Several test series are available. Their analysis. So you should not miss these opportunities. These always will help you score better in your exam. Ultimately, there is no substitute for your hard work, and the question can be framed from any area. It cannot be predicted by any stretch of imagination that these are the questions that are going to be asked in the examination. These are the important areas. These are not. It's not like that. That can be actually predicted for, or in case of university exams or something like that, because where you know that these are the important questions, and these are the favorite question of such and such examiner and all that. In the Viva they usually ask this, that. But in entrance examination, which is MCQ based and the questions are selected on random basis, I don't think anybody can give you an idea about all that. If somebody claims that this is important and this is not, I think that is ridiculous. This is not the reality. Actually, I have framed question for DNB and all that. I know these are all randomly selected. So you can be asked any question related to anything. You don't expect that it should be a question of clinical relevance, then it should be asked and all that. They can ask anything, many a time you will feel that is this the standard of this question, or is should not be framed at all. So Forget about that whatever you are expecting that would be there in the question paper. You should be ready to face anything, any kind of question can be there. And as per the mandate of this NEET PG Plus, or this is inbuilt in the protocol of the NEET PG Plus, that whatever classes you take, after 3 lessons or after 3 classes, you have to take doubt clearing session. So this doubt clearing session are good in the sense that if you have any doubt, though you can ask any question, any doubt, any confusion during the class itself, live class, but many times after some time, later on you develop some kind of confusion, or you come across a new information which you are not capable of decoding that. So you might have question to something to ask from the educator, and that is always good, because inquisitiveness actually keep you going and keeps your learning alive. Otherwise, if you are not inquisitive, you will never grow. That is the problem. You should not study from the point of view of the examination, that I have to crack the examination. You should study in keeping in mind that yes, I have to crack the examination, and I have to retain this information, because I have worked hard to learn so many things, and I won't let it go like this only. I will keep it with me for life, for lifetime. So this is just not the exam is over, so you forget everything, clean and wash out everything. No, you should retain these things, so that this will help you in future as well, because you will never read all these subjects so thoroughly as you are reading right now for your entrance examination. So this is all about Unacademy subscription and all. Let us talk about the topic. Last time we had mammoth discussion on the lipid protein metabolism. That took almost half of the time of the last class, because I feel that unless you know this lipoprotein metabolism, which is a difficult thing, nobody will tell you about all these things. But I believe in making things first. Platform should be correct, then only you can build up any you can erect any building on if the platform or foundation is right. So that is the reason I always explain the basics and then build on that, so that you are able to understand things in a much better way. So that lipoprotein metabolism, I explained everything. Statin itself is a very important class of drug, so that took time. So I just kept my discussion limited to statins and lipoprotein metabolism. Today I will be discussing other group of drugs. Let us see if can we finish today, or we'll have to go for next session as well. Bile acid sequestrants. The name itself suggests they sequester bile acids. Bile acids, where these bile acids are present. These bile acids are present in bile, the least secreted by the liver. So we have several agents. If you know the classification, I mentioned the cholestyramine, and cholestyramine. These are the oldest known, and these bile acid sequestrant drugs, which are used as hypolipidemic agent and are considered to be the very safest, in fact safest drug, because they are not absorbed systemically, not absorbed there. And the other agent like cholestyramine is relatively a newer compound, means it made its appearance late, after many years after availability of these cholestyramine and cholestyramine. So that is why these two drugs are age old, being used since ages for this hyperlipidemia. And these drugs are also recommended in children's. So you can see that these drugs can be used in the children because they are not absorbed. That could be the reason why they are safe in almost all people, all kind of population subset. If you look at the efficacy of these statins, in monotherapy, when they are used singly, means monotherapy means when they are used singly without any assistance of other class of drug, they are capable of reducing LDL level to the desired target. But sometimes it happens that it is not possible to bring it down this LDL cholesterol to the desired level. then in that case these bile acid sequestrants become important. They can be used as an adjunct, and you can add them, because these drugs also decrease LDL. I mean, though modest decrease, not as good as statin, but they do affect plasma LDL level, serum LDL level, and they can also be used in monotherapy when patient is not tolerating statins. So they can be used as monotherapy also, because they are good for decreasing LDL. They have good effect on LDL. So these are the indications for bile acid sequestrant. Moreover, why they are used as adjunct to the statins, because there is a rationale that I will tell you why this is important. Like when also the ezetimibe is a drug which is inhibit cholesterol absorption from the intestine. So that is also considered as a very good drug when it is added to statins. So all this tips I will give you, that why this combination is to be considered and all that. So this is I will be telling you why statins should be added with the bile acid sequestrant. There is a scientific rationale behind it. It's not simply that if you have 10 group of drugs available with you, you can add one with fifth, fourth one with ninth one. Not like that. You should have scientific basis behind it, right? If we talk about mechanism of action of this bile acid sequestrant, I will explain with this textually or verbally. I will explain first of all, and then I will show you the diagrammatic representation of a mechanism of action, so that you will understand it much better. So these bile acid sequestrants, or resins they are called better, these resins are actually highly positively charged molecules. Highly positively charged molecules, and these bile acids are actually negatively charged. So this difference in charge provides an opportunity to attract each other, and these resins bind very strongly with these negatively charged bile acids. And I said already, because these sequestrants or these resins are big in size, so they are not absorbed from the intestine. That is, they are considered safe, very safe. So they bind with this bile acid. If you know physiology, then you will understand everything. In terminal ileum, almost 95% of the bile acid is undergo enterohepatic recirculation, means that is recycled. So this is very important. So if suppose these bile acids are actually bound to these resins and are excreted, what will happen? There will be loss of bile in the body or in the liver, so that deficiency needs to be replenished. So this actually reabsorption occurs in the terminal ileum with there is a transporter called sodium dependent apical sodium dependent bile salts transporter. So that actually transport this bile acids from the intestine back to the liver and all that. So there is a loss, and this loss could be such that the total excretion in the stool may be increased to 10-fold on the daily basis. So what happens? To replenish this deficiency or loss, the liver starts making more and more bile. If more and more bile is being synthesized, bile is synthesized from what? The ingredient is cholesterol, right? So there will be decrease in the cholesterol level, hepatic cholesterol. And if that happens, what will happen then? But the hepatic cells sense it as there is deficiency of the cholesterol. So they do one thing. First, they start capturing, there occurs, I told you about sterol regulatory element binding protein 2. This is a transcription factor which is present on the wall of the membrane of the endoplasmic reticulum. This has been proteolysis happens, and this is cleaved from the membrane, and this is a transcription factor which binds with nuclear or the DNA in the LDL receptor gene area, promoter area of the LDL receptor gene, and it leads to increased production or expression of the LDL receptors on the hepatocytes or parenchymal cells. So more and more LDL can be recaptured from this circulation. So that is one of the way, because LDL is rich in cholesterol, esters and all that. So this cholesterol will be used for synthesis and all that. And also, but this factor is important, that is actually responsible for decrease in the LDL on that, because the hepatic parenchymal cell captures that LDL from the circulation. So this serum LDL level falls. That is good. That is why it is reducing LDL level. But this is this fact is means this action is good, but this is actually nullified by or offset by, this good effect is offset by upregulation of HMG coenzyme reductase, because cells, the hepatic cells also sense that yes, there is deficiency of the bile acid. So not only there is increase in the expression of the LDL receptor, but it start increasing more and more cholesterol. And cholesterol synthesis, this is the rate limiting step, HMG coenzyme reductase. That is the reason why statins actually target this enzyme. So this get overexpressed, so it starts increasing cholesterol. So even if there is loss of cholesterol in the form of bile acids from the intestine, liver is capable of making more and more cholesterol. So this effect of bile acid sequestrant will be nullified. So that is the reason why if we combine statin with bile acid sequestrant, this will be a rational fixed dose combination. Rational fixed dose combination, right? So this is rational fixed dose combination, because that will prevent that will increase the loss, and this will prevent the increased synthesis of the cholesterol. So there will be a dual kind of mechanism of reducing cholesterol level. So this will be actually a kind of synergistic or additive effect will be observed. In fact, synergism may be demonstrated. See this diagram. This has everything that is you are supposed to know about these bile acid sequestrants. Focus this receptors. This FXR. This is farnesoid X receptors. This is a nuclear receptor, and this receptor is actually we have endogenous ligand for this receptor, that is free bile acid and as well as conjugated bile acid. Conjugated, both are endogenous ligand for this receptor. Actually, this receptor is involved in preventing the synthesis, inhibiting the synthesis of bile acids and preventing and promoting the excretion. You can imagine this receptor is actually doing what? It is preventing synthesis as well as enhancing excretion of the bile acids. That is its purpose. It is involved in regulation of this bile acid metabolism and all that. So once there is increased loss of bile, so there is what happens, there is FXR is stimulated, but the stimulation is decreased. It is not inhibited, stimulation is decreased because of decreasing bile acids. Otherwise, actually this FXR, when stimulated by this bile acid, it actually synthesizes a co-repressor, because the nuclear receptors, whatever a ligand bind to receptors, then they recruit co-repressor, co-activators. There are many kind of interaction, then basic transcription apparatus is synthesized and all that. Many these co-repressor activators have histone deacetylase or histone acetylase activities, all these things that is required for transcription. So this FXR actually leads to production of with the help of this it is a co-repressor. It synthesizes a co-repressor that is called SHP. That is, SHP is a small hepatic or small partner. This is, I think, this is if I remember the name, I just tell you. This is uh, a kind of co-repressor that is in that can prevent the transcription activity of the co-repressor transcription activity of many nuclear factors, right? There are nuclear factors that actually, so this is I think this is small hepatic promoter or something like this. So this actually is reduced. Otherwise this prevent transcription of this or activation of this enzyme, which is a rate limiting enzyme in the synthesis of the bile acids from the cholesterol, 7-alpha hydroxylase. This is also called cytochrome P7A1. So this SHP actually is reduced. So there is actually repression or suppression is reduced. So indirectly actually the inhibition of this enzyme is reduced. So this can lead to increased bile acid synthesis from the hepatic cholesterol. So this is how actually it happens. This enzyme is involved in this. So if if bile acids are reduced, then the enzyme or this hepatic cell also start increasing the bile acid synthesis also. And bile acid synthesis is increased, so then more cholesterol will be required. So more cholesterol is synthesized by induction of the HMG coenzyme A reductase. So everything gets activated just because of the reduction in the levels of the bile acids. This activation of FXR receptor is reduced because these are the natural ligand for these FXR receptors. Moreover, other than that, decreased reduction of stimulation of FXR receptors are associated with other factor also. Like increase in ApoC3. This C3 is apolipoprotein, which actually delays the degradation of triglyceride rich proteins or lipids, triglyceride rich lipids like VLDL, chylomicrons, IDL, etc. Right? This level is increased. So what will happen? This is the actually an unwanted effect which is seen with use of this bile acid sequestrant. Nobody wants to increase triglyceride. So this is a kind of effect which is observed with reduction in the LDL level also. So this I am telling you how it happens. So this is because of the increase in ApoC3. ApoC2, if you remember, I told you this ApoC2 act as a cofactor for enzyme lipoprotein lipase. That is why this triglyceride, which is absorbed from the intestine or is there in the VLDL, that is hydrolyzed by lipoprotein lipase to fatty acids, and these fatty acids are taken up by the tissues. Also, this FXR reduction, reduced activation of FXR also leads to reduced activation of PPAR alpha. These are also nuclear receptors. These otherwise actually these PPAR alpha are involved in action of the fibric acid derivatives. I will talk about that. These actually PPAR alpha stimulation actually leads to increase in lipoprotein lipase activity, decrease this ApoC3. It decreases this ApoC3. But here it is increasing because it is reduced, its activation is reduced, and also it increases the beta oxidation of fatty acid. So what will happen if fatty acid will be oxidized? There will be no production of triglycerides, so triglyceride synthesis is reduced. But here PPAR activity is decreasing, so all these effects will be reversed. So that will lead to increased accumulation of triglyceride in the blood. Also decrease in the VLDL receptors. So VLDL is very rich in triglyceride. So liver is not able to take it up, or other tissue cannot take it up. So it remains in the circulation. So it carries triglyceride. Cholesterol to triglyceride ratio is 1:5 in VLDL. 1 cholesterol, 5 triglycerides. So these are triglyceride rich proteins. So there can be increase in the triglyceride level. And this I have already told you that when there is fall in the hepatic cholesterol level, there is increase in this transcription factor, release of transcription factor, that is sterol regulatory element binding protein 2, and that increases LDL receptor expression on the surface. So this is all about this control of how bile acid sequestrant actually act. And HDL is also increased because there is increase in the ApoA1 and all that. So this is also this increase in HDL is not because of something else. It is because of the increased synthesis of its apolipoprotein ApoA1. right? So this can also lead to little increase in the HDL level also. I'm not remembering this actually, this okay, anyway, no problem, you can see that in on internet. So I have already explained you there is increase in the hepatic LDL receptors because there is fall in total hepatic content of the current cholesterol pool of the hepatic cells because of the increased loss of bile acids. So there is increased LDL receptor on the surface that captures more and more LDL from the circulation. So there is reduced serum cholesterol LDL level. And decreased activation of FXR, I have already explained how it can lead to increased triglyceride because of the increase in ApoC3, decrease in ApoC2, decrease in this thing. VLDL receptors are decreased, and also lipoprotein lipase activity may be affected. These kind of things all happens with and decrease the activation of PPR alpha receptors and all that. This reduction in LDLC is dose dependent actually. With increase, with at low dose it occurs lower increase, and at higher doses then decrease is much more, lowering effect is much more. Usually the doses of these resins is very high. For example, this cholestyramine is used up to 24 gram per day, and cholestyramine is up to 30 gram per day. So usually initiating dose is 8 to 12 gram of cholestyramine and 10 to 15 gram of cholestyramine. These all can reduce LDL level up to 12 to 18%. And if you increase to the maximum dose, that is at 24 gram of this and 30 gram of this, we can achieve up to 25% of LDL reduction. But usually at these doses, the tolerability of these agent is a cause of concern because GI tolerability is an issue. So this is the problem, and that is why they are considered as good when they are combined with something like statins and all that. So what happens, you need only some maximal doses, so tolerability is good also, and there is also synergistic action, right? Maximum effect on decrease in LDLC level is occurring in 1 to 2 weeks. Similarly, statin also 7 to 10 days was there. And whenever they are used with statins, I told you to improve their tolerability, used in submaximal dose, because synergism can occur, and that is sufficient to improve the probability of achieving target LDL level when they are used with statins. These drugs are usually available in the powder form. This cholestyramine is also available as tablet, powder and tablet, and cholestyramine is available as a gelatin capsule, hard capsule, which is gelatinous. That is not available as a powder. So these powder, how to take? You should not take powder directly, otherwise it will cause choking and all that. So you have to suspend this powder or mixed in fluid, anything, let it be water or any juice. You can mix it with that, and a kind of slurry is formed, and you can drink that slurry twice a day, and that is usually taken before breakfast. And why before you are taking something and evening supper? Why? Because they act well when this bile acid will be maximally secreted. When there is you take something, you eat something, then only there is constriction of the gallbladder and release of the bile and all that. So then only if it is fatty meal, then it is more chances that more and more bile will be secreted. Fine. So it is to be taken before that to ensure maximum activity of these. If we talk about adverse effects of this bile acid sequestrant, the very common side effect, as I told, that is the these drugs are very good effect on the this LDL level, but because of these GI side effects, they are tolerated, not well tolerated. That is why they are more commonly used as adjunct to statins so that they can be used in some maximal doses and reduce these complications. So mainly this bloating and dyspepsia. The bloating and dyspepsia is quite common with cholecyclum and not cholecyclum, cholestyramine and cholestyramine. And this can be reduced. First you start dosing, as I already told you, that one should start with the lower dose and gradually can increase, because the suddenly taking higher doses can cause intolerable side effects. This can be reduced by this idea is there that if you suspend this powder in water or any juice, well before they are being consumed. Suppose it is to be used at breakfast. So breakfast dose can be prepared a night before, it means night prior to the breakfast. So suppose you want to consume tomorrow morning before breakfast, so today night you prepare it, suspend it in the water, keep it like this in the fridge, and then cold, and you can take it in the morning. And same if you have to use it before supper, so you prepare it in the morning. So this has been found to decrease these side effects. And constipation may also occur because of these drugs, and that is why these drugs are to be avoided in patient have any kind of bowel obstruction or motility disorders and all that can lead to problem, But this cholecyclum is supposed to have less of these complications like constipation and bloating. However, this constipation can be reduced by ask patient to ensure adequate water intake, a lot of water intake, and also if necessary one can use psyllium husk, that is also called ispagula husk, or in local language it is called isabgol. We all know isabgol, right? So these are this constipation can be taken care of by this adequate water intake, and if necessary this psyllium and or isabgol. These drugs, this powder and all that, as I said, this powder should not be taken as such. It should be mixed in water, sufficient amount of water, so that you can take it as a slurry. This cholecyclum, as I told you, is available as a hard capsule which is gelatinous. This also is come in contact with water and forms the gelatinous substance. So also this is required to have sufficient water along with it when you take it. And whenever you are using tablet of the cholesterol, you should take it with sufficient water, because that will also be formed as a slurry inside the intestine. So that is necessary. One complication, because these all agents are usually administered as hydrochloride salt or chloride salt. So there is, because you are taking 30 grams, 24 grams, a lot of chloride is also delivered to the intestine, and this may sometimes lead to hyperchloremic metabolic acidosis. Sometimes, especially in the when patient has renal impairment, because it is not possible to maintain this acid-base balance because of the renal impairment. So that is why caution is exercised when patient is having renal impairment and all that. And this is contraindicated in those who have hypertriglyceridemia more than 300 mg/%, because I told you these drugs can increase triglyceride level, which is an unwanted effect, and so these patient who are having hypertriglyceridemia can more than 300 milligrams should contraindicate. And this is more common if patient has triglyceride, means triglyceride increasing properties more when the patient has initial triglyceride more than 250 mg/%. In those, Those who have normotriglyceridemia, then that is not much rise in triglyceride, but those who have more than 250 milligram, then it is it is there. So it is contraindicated in those who have more than 300 milligram %. And complete biliary obstruction, then it is a contraindication, because if biliary obstruction there will be no loss of bile and all that, and that will be not effective. It is contraindicated. Let us talk about this and drug interactions. This it is a gelatinous substance, and you're taking a lot of quantity in grams. So this, by its physical interaction, I told you a number of times that many drugs act through either receptors or ion channels or transporters or enzymes. Some act through chemical mechanism, some by physical mechanism. There could be many ways. So this is simply a physical interaction. This drug acts by its physical activity or physical properties. So it's simply because it is a gelatinous kind of substance, it can physically inhibit drugs to get in contact with the mucosa and intestinal mucosa and prevent their absorption and promote their excretion along with it. So this is why these kind of drugs should be avoided with any kind of therapy. There should be a minimum gap should be kept between this resins and other drugs. So for example, the more commonly are seen with L-thyroxine, digoxin, warfarin, some of the statins even. So when they are added with statins, we are saying that we will get a synergistic effect, but some of the statins may be affected by their absorption, may be affected by these drugs. And statins, first of all, they have very variable absorption, and also they have reduced means very variable, low and variable viability. Can also lead to loss of or decrease absorption of fat soluble vitamin A, D, E, K if used on prolonged basis. Also the thiazide diuretics, many furosemides and all that, many drugs can be affected, though list may be very long. It's not possible to include each and everything, but these are important. But the cholecebulum, it is supposedly rarely interfere with absorption, but we cannot take chance. It will be our prudence to have this preventive strategy, such as spacing the administration of the other drugs by a sufficient duration of time, so that this physical interaction does not occur. Can be used in pediatric patient or pregnant women. This is considered as category C, means you have to assess risk benefit or do risk benefit analysis. Most of the drug fall under this category C, that it is the call of the physician or treating clinician to decide whether go for it or don't go for it. So most of the drug fall under this category, pregnancy category C usually. As I said, use with caution in renal impaired, because there is increased risk of metabolic hyperchloremic metabolic acidosis, and there is increased chances of when there is patient is having hypertriglyceridemia. Then also use with as I already said, 300 se upar hai to you don't have to use at all, but otherwise you keep a check on the triglyceride level. So if patient with hypertriglyceridemia, you should be little cautioned and keep a watch on the triglyceride levels. And after 4 to 6 weeks, you go for a fasting lipid profile. Ask the patient to get it done, a fasting lipid profile. And if you find that triglyceride levels are above 400 milligram %, then this is the time to discontinue these resins. Then they will cause more harm than benefits, right? And anything if is there any cause of secondary cause of hypertriglyceridemia, for example alcoholism and all that, or diet is such that is rich in saturated fats and all that, trans fat. So these kind of causes should be controlled. Then the chances of increase in triglyceride will be less, because these are the other sources of triglyceride which are being received from the dietary intake. Moreover, prolonged use increases the risk of bleeding. This is I was talking about, because prolonged use can lead to decrease in the absorption of fat soluble vitamins. So vitamin K is important in coagulation and all that, because reduced vitamin K is important for gamma carboxylation of the terminal glutamate residues of factor 2, 7, 9, 10. And this is important, this GLA-domain formation is important, or this gamma carboxylation is important, because then only they can attach with calcium, which is very important in any clotting mechanism. Should be avoided in constipation. Avoid constipation in CHD patient, yes, because they can cause constipation. So constipation, usually what happens, the patient may apply pressure and can push it, and so that can suddenly increase heart rate and all that, and sudden increase in blood pressure and all that. So that can be little dangerous for CHD patients. So you should keep a watch on the constipation and try to avoid it by using spagula husk or something like that, or other mechanisms, because such patient, if they apply pressure while during passing stool, that can lead to sudden rise in blood pressure and also increase in the cardiac oxygen and cardiac stimulation also. Should never be ingested at powder. As I told you, there is a risk of choking and all that, and also when you take it as powder, then it will get if there is no if you do not give extra water from the outside, it will form a semi-solid kind of content inside the intestine, and that can block intestine also. So this is to be avoided as powder. And as I told you, as a preventive measure to avoid absorption of other drugs, you need to maintain gap while administering the other drug. Though it has been told that scopolamine is unlikely to cause this kind of interaction, but that we do not have established or confirmed information on that. And so in non-availability of such information, it is always good to have this preventive measure. For example, you either administer this drug 1 hour before administration of other drug, or at least 4 hours after administration of these resins. So this much difference you have to maintain. So this is how you can avoid these clinically significant drug interaction and all that. So this was all about bile acid sequestrant. We found that these agents are good for decreasing LDL, but one problem is there. They can increase triglyceride, especially in those who have baseline triglyceride level higher than 250 milligram percent. So you should be little vigilant about all this triglyceride level. And also the secondary cause of triglyceride in hypertriglyceridemia should always be addressed before we start this therapy, so that actually lessens the risk of triglyceridemia. And the reason why triglyceride increase in there, I already told you, because of the reduced activation of farnesoid X receptor by the bile acids will lead to decreased activity of PPR alpha, increase in ApoC level, decrease in ApoC3 level, decrease in ApoC2 level, and as well as VLDL receptors. So clearance of these triglyceride rich does not occur lipoprotein. So there is increase in serum triglyceride. Niacin, we know it since class 6 or 7 that it is a vitamin B, part of vitamin B complex vitamins. It is a fat soluble vitamin, and it acts as vitamin only when it is available in the form of NAD or NADP. That is, it's where it exists as an amide. Actually, it is also known as nicotinic acid. So if you administer this as niacin or nicotinamide, it will act as vitamin, because ultimately niacin will also be converted into nicotinamide in the body, and that is the actually active form. But nicotinamide will not act as affect the lipid levels. It is the niacin that actually affects the lipid level. But the amount which is required for as vitamin supplement, the quantity to act as anti-hyperlipidemic or hypolipidemic agent, the dose is very high in grams, in fact. So this is the difference, and it is the niacin, which is inactive form of vitamin, which is actually effective in reducing lipid levels. If we talk about its mechanism of action, its major mechanism is there in the adipose tissues, major target actually, where it actually act and inhibit the lipolysis of triglyceride. I will tell you how it is possible. So what happens? The ingredient for triglyceride is broken down into what? Fatty acids. So fatty acid actually this is a raw material for triglyceride synthesis in the liver. So less of triglyceride synthesis occurs there because fatty acids are not available there, less available. And adipose tissue, it is a storehouse for the triglyceride and all that. So whenever body needs, it can be mobilized from adipose tissue. And it acts through G protein coupled receptor that are expressed on adipose tissues, and I will show you that. And in liver, actually, when there is less of triglyceride synthesis, actually what happens, triglyceride is synthesized from the fatty acids, and this triglyceride is to be incorporated into VLDL because that is the triglyceride rich. And this VLDL, after incorporating in the VLDL, it has to be attached with ApoB, because which is a apolipoprotein which binds with VLDL and responsible for its movement in the circulation. And that is, this reaction is carried out by MTP, microsomal triglyceride transfer protein. I told you that. If that doesn't happen, what will happen? This ApoB is degraded. So this leads to increased ApoB degradation if ApoB is not there, because VLDL production is reduced because there is no fatty acid, no synthesis or reduced synthesis of triglyceride by the liver. So VLDL is also reduced. When VLDL is reduced, then LDL will automatically be reduced, because ultimately I told you while I was teaching lipoprotein metabolism, whatever LDL is there in the serum has all been derived from the VLDL. VLDL is broken down into IDL. From IDL it is broken down to LDL. So LDL is poor in triglyceride, rich in cholesterol ester. So this is LDL actually. This is an indirect effect. There is decrease when hepatic LDL production is reduced. Serum LDL will reduce, right? Other than that, this niacin can increase LPL activity. I'll show you this lipoprotein lipase. So what will happen? That will all break down all triglyceride rich proteins like VLDL, chylomicron remnant, and it is converted into fatty acids. So there is increased clearance of triglycerides in the chylomicron and VLDL. Decreased clearance of ApoA1 in the HDL. So ApoA1 is a very important apolipoprotein which is associated with HDL. And if there is decrease or deficiency of ApoA1 or defect in the gene of the ApoA1, there will be very much low HDL, and this ApoA1 is considered as independent risk factor for atherosclerosis. This is alone is considered as risk factor. So this ApoA1 is very important for HDL, though ApoA2 is also there, but ApoA1 has more importance in case of HDL. That is why it is called alpha, high density lipoproteins, the alpha lipoproteins. LDL, VLDL, they are all associated with B, ApoB. ApoB could be, chylomicron is also, so chylomicron is with ApoB48. These LDL, LDLs are ApoB100, all these things. That is why they are called beta lipoproteins. See the mechanism of action. This is the adipose tissue, adipocyte cell. So triglycerides are stored as fat in the adipose tissues. So usually there is a receptor called hydrocarboxylic acid 2 receptor. This is also known as niacin receptor 1. Actually, this is a receptor for niacin. This is also named as GPR109A. So this is a G protein coupled receptors and are associated with inhibitory GI. So it will inhibit adenyl cyclase activity. There will reduce in cyclic AMP. There will reduce in protein kinase A activity, and that actually reduces the activity of this hormone sensitive lipase. Also, adipocyte triglyceride lipase. There is enzyme. So what happens? The lipolysis actually reduces here. These actually, this is in adipocyte. This lipoprotein, this triglyceride is not broken down into fatty acid, decrease. So what happens? Less of free fatty acid is generated and less free fatty acid is delivered to liver. So what happens? So triglyceride synthesis will be reduced. Not only that the raw material is in shortage, also this nicotinic acid affects the activity of diacylglycerol acetyl transferase 2 enzyme, which is involved in the triglyceride synthesis in the liver. That enzyme is also, so its activity is also affected. So there is a reduced delivery of the raw material. Also the enzyme which is involved in triglyceride synthesis, that is also affected. So what will happen? There will be less of VLDL formation, because triglyceride is the major component of the VLDL, and VLDL if not formed, so secretion, how the liver will secrete when product is not available, warehouse is empty, there is no in go down, no, nothing is there, so how it will reach to the retailer? So secretion is also reduced, and whatever secretion is there, what happens? There is increased lipoprotein lipase activity, also LPL activity is also increased. I told you LPL activity is also increased. So what happens? Whatever VLDL is moving, that is also broken down into means hydrolyzed. So triglyceride is reduced. Fine, and because of that this is hydrolyzed, so it is converted into LDL. So LDL is reduced, so VLDL is reduced, so LDL is reduced, so this is LDL decreasing effect. And triglyceride decreasing effect I have already told you. And because of this also triglyceride reduced, because VLDL is reduced, everything reduced, because they all carry triglyceride in the serum. So because of that, serum triglyceride level goes down, and it also A1 level is increased. So because of this, HDL-C level is increased. So it has effect in almost everything. But despite having these good effect on all type of lipoproteins, this is because of tolerability issues, this drug is very less commonly used, because it has a lot of side effects which are intolerable in fact, right? So did you understand everything? Right. See this ApoC3. ApoC3 is reduced. Actually ApoC3 is involved in prolonging or delaying the lysis of or lipolysis of triglyceride rich protein or triglyceride rich lipoproteins. So if it is reduced, it means indirectly there will be increased hydrolysis of VLDL. So that is what happening. So VLDL is reduced because it is if there is lipolysis has occurred, lipoprotein lipase. So what will happen? It will be converted into LDL. And since there is decreased secretion from the liver, so all will be reduced, LDL-C and all this, and HDL-C is because of the increased A1. This niacin has an issue that though it is absorbed, okay, fine, but its half-life is only 1 hour. And it is usually several preparations are available. I am talking about the regular niacin, or also called as crystalline niacin. So half-life is 1 hour, so it is to be given 2 or 3 times daily. That is a problem. And when it is used at lower dose, it is usually, most of it is taken up by the liver. And in liver it is metabolized, and its metabolic product is nicotinic uric acid. Nicotinic uric acid, that is actually, that appears in the urine and released excreted by the kidney. But when you use in large doses, what happens? It is also converted into other metabolites also, and a large chunk of the active nicotinic acid, that is nicotinic acid, nicotinamide is excreted by the kidney, because it is not totally metabolized. Fine. And it reduces triglyceride by 35 to 50%, especially those who have high triglyceride level. Initial triglyceride level If it is high, then it reduces triglyceride level. Not that it reduces triglyceride by 35 to 50%, that you can imagine, in 4 to 7 days. And this is as good as almost caused by fibrates, or in some cases like statins reduce triglyceride more oftenly when the triglyceride levels are higher than 250 mg%. Then it is the proportion of fall is more with statins, right? Otherwise it is modest. LDL-C level can be reduced by 25% if the higher doses are used, and this can happen with doses usually taken as 2 to 6 gram. But this can happen only when the higher doses like 4.5 to 6 gram is used per day. So up to 25% can be, but it takes time. It takes time, around 3 to 6 weeks. It is not as quick as was occurring in the cholestyramine or in case of statins, And this nicotinic acid, I also told you earlier also, this is the drug which is most effective agent in increasing HDL level. So those who have low HDL can be, this HDL can be increased significantly, maybe 30 to 40%. But especially in those who have baseline low level of, per deciliter. 35 milligram means less than 35 milligram, then only, because if it is lower light from the beginning, then increase is more visible or demonstrable in these patients. So it is reducing triglyceride, it is reducing LDL-C level, it is increasing HDL level to the significant degree, and it also reduces LPA, and this is the only hypolipidemic agent which actually reduces LPA level. No other drug till date has shown to reduce LPA level, and this reduces it significantly. I told you this LPA is nothing but it is just like LDL molecule, but LDL molecule has B100, but this LPA, as the name suggests, it has another in place of in addition to B100, it also has ApoA, and its structure of ApoA is just like plasminogen, but it is not activated by tissue plasminogen activator, but it interferes with fibrinolysis that occurs, fibrinolysis of the thrombus that occurs on the atheromatous plaque. If there is atheroma and some clot is made there because of rupture of the foam cells or all that, so in thrombus it prevents fibrinolysis. So this is, and it is considered as highly atherogenic protein, lipoprotein. So this is the drug which affects all form of lipoproteins favorably, but its use is limited, as I told you, is limited by the side effects which are there because they are not tolerable by the patients. So a very good agent, but because of tolerability issues, So these are the recommended or indications for which this drug is to be used to reduce. These are all recommended by US Food and Drug Administration, that is to reduce total cholesterol, to reduce LDL, to reduce triglycerides, to reduce ApoB level, and to increase HDL. You can see that separate is there to increase to decrease ApoB level if it is in some genetic defect because of this ApoB is increased. If ApoB is increased, it will definitely increase the LDL and all that, because this is the apolipoprotein for this LDL, VLDL and all that, so that will increase. So this is also indicated for that. And this is another indicator, reduce the risk of recurrent non-fatal MI in patient who have history of past MI and having hyperlipidemia. Also it should be used, this niacin should be used with this bile acid sequestrant resins to slow the progression or slow the progress, slow the progression, galat aa gaya this word actually, slow the progression of atherosclerotic cardiovascular disease in those who have CAD, history of CAD with hyperlipidemia. It can be used as adjunctive therapy in severe hypertriglyceridemia. Adjunctive therapy, I'm telling, it is not as alone, it is to be used in combination with dietary control. Dietary control means severe restriction in the dietary triglyceride, means fat and all that should be curtailed. Even if that is not target triglyceride levels are not achieved, then it can be used as adjunctive therapy, because there is in case of severe hypertriglyceridemia there is a risk of pancreatitis, acute pancreatitis. For that reason, so these are all indications of and these drugs can affect liver function, so you need to monitor liver function test also, so keep doing liver function test and measure uric acid. These are problem, because niacin can cause increase in uric acid, like pyrazinamide and levodopa and diuretics or all these drugs can cause increase in uric acid. I was talking about different preparation of niacin. I told you regular niacin, that is crystalline also, that has certain issues for which sustained release preparation was made, and other is extended release preparation, which is needs to be given only once daily at bedtime, and this is the prescription only medication. These two are available as OTC also, So this ER niacin, extended release niacin, when it was actually tested in clinical trials and all that, it was found that there is no reduction in the CV mortality or morbidity with extended release niacin, but with other niacin it was found. So this regular niacin is also known as immediate release, sustained release, extended release, 3 preparations. So this immediate release is called regular niacin or crystalline niacin. So we should, because I told you the major issue with these drugs is tolerability. So we should start, though it is to be taken twice or thrice daily, but you start with 250 milligram OD only. Gradually every 7 to 10 days you keep increasing, ultimately you reach to 2 gram. This dose is usually tolerable maximum. Otherwise maximum dose you can go up to 6 gram per day. So after, if you are stabilized on these dose and measure all these things, this uric acid, LFT and all that, and remain on this dose for 4 weeks, and then also can increase if you want that goal has still been not achieved, you can increase if it is tolerable, so you can go maximum up to 6 gram. But this extended release or sustained release are maximum given up to 2 gram. This is extended release is once daily, but sustained release is maximum 2 gram. If you use more than 2 gram, then there is a risk of hepatotoxicity. This is to be taken at the bedtime every day and can be used up to doses of 2 gram. So they are effective up to doses of 2 gram. SR niacin, sustained release, when it is taken at the dose more than or equal to 2 gram per day for a long time, it can lead to serious hepatotoxicity. And ER niacin, extended release, is less likely to cause hepatotoxicity, just because this justification has been given because it is taken once daily only. That is the reason it has low propensity to cause this hepatotoxicity. Another important issue, the basic issues which are, these are safety issues, hepatotoxicity, myopathy. But other things, these things are tolerability issues. They are not safety concern, but these are safety concern. If not corrected or treated, can lead to death of the patient. Myopathy can be life threatening if it can lead to rhabdomyolysis and all that. But these things will not be life threatening or safety concern. They are not safety concern, they are tolerability. Because of these issues, patient is not able to take drug. Pruritus, let it be any how severe it is, severe pruritus, but that cannot harm your health. But because of that, you will not take drug. The tolerability and safety has important differences. Please remember this. Okay. So usually myopathy risk increases with statins, especially I told you because nicotinic acid, the mechanism is different. It is enhanced this HMG coenzyme reductase inhibition in the skeletal muscles also. That is the reason. That is pharmacodynamic interaction. Otherwise many drugs were causing because of the increase in the plasma level like gemfibrozil and all that. So, but in cases where the patient is intolerant to statins, this nicotinic acid should be considered as monotherapy on those patients can be used. Like I told you, when there is statin intolerance, you can use bile acid sequestrant. This can also be. And in USA, these fixed dose combination with statin, this nicotinic acid, gemfibrozil, all have been removed since 2016 because of there is no additional increase in the efficacy, and moreover there is increased risk of myopathy. These are the side effects which are usually of concern and which actually make this drug less preferred by clinician as well as by patient for the treatment of hyperlipidemia. Flushing, it can lead to dyspepsia, pruritus mainly involving the face and the upper trunk, skin rashes, acanthosis nigricans. These are acanthosis nigricans are more common in diabetic patients. That is actually can signify insulin resistance even. Acanthosis nigricans. Today you just find out on internet that how this acanthosis nigricans images. Just check. It is back of the neck, in the axilla and all that. At many places it is present. Acanthosis nigricans, right? And usually this flushing is because of this and pruritus is all because of the these are all are prostaglandin mediated, and it occurs more when chances are more when you initiate the therapy or when you increase the dose of the therapy. Then this flushing is much more common. And as I said, these are all prostaglandin mediated. Then they can be controlled can be reduced by taking aspirin daily, or before taking the dose you can take any NSAID half an hour to 1 hour before that. Also this flushing risk increases when you take it with alcohol or if alcohol is there, and or you take it with any hot beverages. So all these things can increase the risk of flushing. Also there is dryness of the skin and all that. So for that it is advised that for flushing and pruritus, I already told you aspirin or other NSAIDs. Dry skin, all that you can manage that with moisturizers and all that. And acanthosis nigricans can be managed with some local preparation which contains salicylic acid, because there is skin thickness and all that, black becomes and hypertrophied skin kind of thing. Acanthosis nigricans. This flushing and dyspepsia and all that can be reduced if you start with a low dose and with meal. Usually take after meal. Then these kind of problem can be minimized to an extent. But tolerability is a major issue with with this nicotinic acid. And because of these reasons, because of dyspepsia and all that, it should be avoided in patient with peptic ulcer disease. And moreover, this nicotinic acid can cause severe insulin resistance and can vitiate your blood sugar control. So for the diabetes, they should go regular, every week their blood sugar should be checked so that their anti-diabetic medication can be stabilized properly. And so this should be avoided in these patients. Gout, because it can precipitate acute attack. Pregnancy, because in pregnancy it has been found that in animals studies that birth defect has been induced by this nicotinic acid, because such a high dose. So avoided in these conditions. And some rare side effects like reversible toxic amblyopia and maculopathy can also occur with nicotinic acid, this high dose of nicotinic acid. So one should, this can be questions, this kind of things. I told you that anything can be asked as a question. What is there in the mind of the examiner? And moreover, these all are taken randomly from the question bank that is there in the computer. So the predictability is not there, but only thing is they can program it as that take so many questions from this particular subject, this many from this can be programmed. And also this also can be programmed that take 1/3 as a difficult question, 1/3 as easy question, 1/3 moderate difficulty, because all the questions which are there stored in the question bank is always assigned a difficulty level as well. So that can also can be done, but nobody knows that the question should be taken from this particular topic or that this cannot be done, So, and there is random selection, so there are high likely chances that there will be very much, because they are randomly selected, so there will be very less chances that the questions are randomly selected from one topic, like out of 25 questions, 20 questions are from endocrinology. It cannot happen. It does not happen, in fact, right? So guiding you or giving you tip that this particular chapter is important and this is important. That is why I always say that this topic is important, because these kind of drugs are more commonly will be used by you more commonly during clinical practice and all that. I take this that way actually, not for this, that I am not teaching for your examination that this is for this question can come and this one, but I keep telling you also, because the purpose of the platform is to make you ready for, prepare you for entrance examination. But I cannot suggest any question that this can be asked. This can be framed as a question. I can tell you this can be framed as a question. This nicotinic acid is metabolized by two pathways in the liver. One is conjugation pathway, another is amidation pathway. The difference between these conjugation pathways has high capacity, can metabolize large concentration of nicotinic acid, but it has low affinity. But amidation pathway has low capacity but high affinity. So why there is increased risk of SR niacin, more risk of hepatotoxicity with niacin, because it is being released slowly. So lower serum concentration are maintained for longer time. So this amidation pathway becomes important. Why? Because it has low capacity, so concentrations are less, so less of the drug is delivered to the liver all the time. So this pathway has become important, because it also participates in metabolism. And this conjugation, and this has high affinity, so at low concentration, because of high affinity, it will become more important. So this amidation, actually this conjugation leads to formation of nicotinuric acid. So that is actually this conjugated products are excreted by the kidney 60 to 90%, and less of it actually this is So this conjugation pathway is more important when higher concentrations are available, and amidation becomes more important when lower concentration available. So this amidation pathway leads to production of nicotinamide, because amidation is important to make this niacin active as vitamin. Otherwise this will not be active, as the niacin as such is inactive as vitamin B. And ultimately this nicotinamide is broken down by various enzymes to many oxidative and reductive metabolites. So these all can interfere with the hepatic cells and all that, and can increase the tendency of liver toxicity. This is the reason has been given for increased toxicity with SR niacin. So this is high affinity, low capacity, and this is low affinity, high capacity. So this is the actual usual metabolite, nicotinic acid, right? And the speed of metabolism is in between in immediate release and sustained release. This ER niacin fall in between these. So we have already covered nicotinic acid, we covered bile acid sequestrant, and you could know this nicotinic acid, such a wonderful drug, has ability to affect almost all form of lipids in favorably, but sometimes a person may be very good, but because of one difficulty or one bad quality, he loses all his importance and all that in the society. So same is here, because it has poor oral tolerability, and because of that this drug is preferred less by clinicians and by patients as well. So the fibric acid derivatives actually are mainly used for reduction of the triglyceride mainly. These are used mainly in hypertriglyceridemia. So usually it was said that mechanism of action by which this fibric acid lower lipoproteins means triglyceride and raise HDL is not known, not very clear, but actually there is enough research in this area, and this has been found that these are the pathway that may result in the that may mediate the activity of these fibric acid derivatives. So major action of these fibric acid derivatives to bind to this alpha, that is peroxisome proliferator activated receptor alpha. This is a nuclear receptor, just like I was talking FXR, and you must have read PPR gamma. I talked about that in on plus classes in anti-diabetic drugs. Thiazolidinediones like pioglitazone, rosiglitazone, they act through PPR gamma. And pioglitazone has some activity on PPR alpha. That is why it has triglyceride lowering effect also. It is effective in diabetes, reducing blood sugar, and most important dyslipidemia in diabetic patient is increased triglyceride level. So that take care of the triglyceride also. So it offers dual advantage, pioglitazone especially, right? So it binds to PPR gamma and reduce triglyceride through action on increasing free fatty acid oxidation, beta oxidation of free fatty acid by the liver, and increase lipoprotein lipase synthesis in the liver as well as in the wall of the vessels and all that, and decrease in the ApoC3. I told you this ApoC3 is actually a apolipoprotein which delays catabolism of triglyceride rich lipoproteins. So if its level is reduced, it means indirectly there will be increased catabolism of triglyceride rich lipoprotein, then the serum triglyceride will be reduced. So that is why this drug is important, and this lipoprotein lipase will hydrolyze triglyceride to fatty acid, and they will be deposited in the adipose tissue and will be utilized by other peripheral cells. And it actually increases beta oxidation of free fatty acid, so there will be less of ingredients available for the synthesis of the triglyceride by the liver. So all factors ultimately leads to decrease in triglyceride. But it also increases ApoE. This Apo is important. This is present on the many triglyceride rich lipoproteins. So ApoE actually act as a ligand for LDL receptor or LDL receptor related protein. So can be taken up, this triglyceride rich protein can be taken, lipoprotein can be taken up by the liver. So they will be cleared from the circulation. It also increases ApoA1 and A2. So these two are apolipoprotein for HDL. So there will be increase in HDL also. And ApoC2, it increases ApoC2. ApoC2 is important cofactor for lipoprotein lipase enzyme. So it will increase the activity of lipoprotein lipase, so more hydrolysis, right? So this is all can lead to, now you can understand why there is decrease in triglyceride level and increase in HDL level. This ApoC3, I told you, this actually interferes with the catabolism triglyceride lipase, and it can affect serum triglyceride level by both extracellular matlab it decreases the activity of LPL, lipoprotein lipase, right? And also decreases the activity of this ApoC2, which is important for lipoprotein lipase. And intracellularly it affects the hepatic triglyceride synthesis, inhibit hepatic triglyceride synthesis. So it affects hepatic triglyceride synthesis and also its secretion by the liver. So it acts both intracellularly as well as extracellularly. This is the diagram. This is the simplest one, that stimulation of PPR alpha. This is inhibition. It is showing inhibition, and that is showing stimulation. So lipoprotein lipase activity is increased. There is increased lipolysis. So triglyceride is converted into fatty acids. And here ApoC3 is inhibited or reduced. So ApoC3, I told you, ApoC3 is inhibit triglyceride rich catabolism of triglyceride rich lipoproteins. So there is decrease in the triglycerides. It leads to decrease in triglycerides. And this is more detailed diagram. You can see this is this lipoprotein lipase. So there is increased transcription of lipoprotein lipase. These are endothelial cells. This is actually nucleus. So there is increased lipoprotein lipase expression, transcription of LPL. So increased, and this because lipoprotein lipase hydrolyzes all the triglyceride rich proteins like VLDL, like polymers. So fatty acids are produced, and these fatty acids are taken up by skeletal muscles or cardiac muscles for using as an energy source, and also they are taken up by the liver, and where it is increasing the fatty acid oxidation, beta oxidation of fatty acids. So that is oxidation is occurring, and this also this fatty acid oxidation can occur in this skeletal muscle because it will lead to formation of or give rise to ATP generation, all that. And in blood vessels, I told you this VLDL all are hydrolyzed. Hydrolysis of VLDL and chylomicron triglyceride is hydrolyzed, and this is liver. So in liver there is decrease in ApoC3 synthesis, I told you, because of the activation of PPR gamma. Increase in ApoA1 and ApoA2, so there is increase in HDL. This actually reduces, it produces hepatic triglyceride synthesis, etc. decreased, and because of that PPR alpha activation, the fatty acid oxidation was increased. So there is oxidation products and decreased ingredients available for the synthesis of triglycerides. So they see if fatty acids are oxidized, there is no lesser synthesis of triglyceride, and also there is no secretion of the triglyceride. So ApoC3 is playing a role here, and moreover there is increase in ApoC2 also. This is not been shown here, which act as a this for cofactor for LPL enzyme. So this is how these fibric acid derivatives can reduce plasma or serum triglyceride levels and raise HDL level as well. The fibric acid derivatives are absorbed rapidly and absorbed almost completely, or almost 90% of them are absorbed, but absorption is more with meals than on the empty stomach, so they should be taken with meals. And if you talk about the half-life of the fibrates, we have many, like gemfibrozil is not this has a very short half-life, and we have other derivatives like bejafibrate, ciprofibrate, clofibrate, fenofibrate. Fenofibrate is very commonly used fibrate, though bejafibrate and this ciprofibrate are also available. Gemfibrozil is also available. So this half-life can vary 1 hour for gemfibrozil to 20 hours for fenofibrate. You can imagine how much difference is there. They are quite variable. Half-life is quite variable. And after absorption, these drugs are actually distributed all over the body, and very high concentration are achieved in liver, kidney and intestine. And here concentration is higher than the plasma concentration. So they are accumulated or concentrated in these tissues. and this JAM fibrogel can transfer the across the placenta, so it is these drugs are usually avoided in pregnancy. And excretion may be impaired in renal failure because 60 to 90% of these fabric acid derivatives are actually handled by the liver. They are conjugated and excreted in the urine, and smaller quantities also excreted in the feces. So impaired renal failure can lead to accumulation of these drugs. So that should be actually the caution should be exercised while using renal failure. This is all kinetic, that is absorption, distribution, metabolism, and excretion. This is pharmacodynamic effect. The action of these fabric acid derivatives is based on many factors. For example, it depends upon what was the initial triglyceride level in the individuals before the start of the therapy, or any defect, means congenital presence of or absence of some lipoprotein, this hyperlipoproteinemia, etc., or anything other than that is dietary, how much dietary, secondary causes of triglyceride levels and all that. So it has been found that the most sensitive subset of patients are those who have type 3 hyperlipoproteinemia. They are the most sensitive patient in which the triglyceride level can be reduced to the maximum, and these patients are also called dyslipoproteinemia. This condition is also called as dyslipoproteinemia or remnant removal disease, and it is characterized by increase in serum IDL level. These are very important diagnostic, in fact, and these patients are also very characteristic in this type 3. They have xanthomas. So because of the action I have explained, this all lead to elevated triglyceride level is lowered, and not only that, these drugs can improve angina, improve intermittent claudication also. What was the drug used in intermittent claudication? Silastazole, I told you, antiplatelet drugs I was talking. And these xanthomas may regress or may disappear completely. Many times they can be palmar xanthomas, they can be under the skin, they are swelling kind of pustule kind of thing. So they can decrease triglyceride by up to 50%. You can see, that is why I was saying with nicotinic acid that can be similar to, many times can be similar to fibric acid derivative, and it increases HDLC by 15%. But the LDLC level may be unchanged or increase, especially with this gemfibrozil, this fenofibrate. But can increase usually with high doses. Usually with this fabric acid derivatives, gemfibrozil may increase or remain unchanged. But if with gemfibrozil, the LDCL level may change or increase gemfibrozil. But these fibrates may reduce LDL, not as such. In heterozygous familial hypercholesterolemia, may reduce. Otherwise, this is the problem. Like bile acid sequestrant, we were seeing that there was increase in triglyceride, and here with this drug which is reducing triglyceride, but we can observe increase in LDLC. So this is with gemfibrozil especially. So you should know that it is easy to remember that bile acid sequestrant, they are mainly for reduction of LDLC. So they are increasing triglyceride, and these fibric acid derivatives are mainly for reduction of triglyceride. So they tend to increase LDL. So this way you can remember. But this can also reduce LDL in case of heterozygous familial hypercholesterolemia. But this gemfibrozil do not affect in this case, and in fact can little increase LDL level. But these drugs, fibric acid, the primary therapy of the type 3 hyperlipoproteinemia, that is just beta lipoproteinemia, is to remove the primary cause. that is, you reduce the alcohol intake. These are the primary cause of type 3 kind of thing, though there is deficiency, this genetic defect, but hypertriglyceridemia is mainly because of all this. And dietary fat intake should be reduced, and this can act as an adjunct to these therapy, primary therapy, that is lifestyle modification. And this can improve by enhancing the catabolism of clearance of the triglyceride in terms of increased fatty acid beta oxidation, or can decrease synthesis. Increasing clearance and decreasing synthesis, both are there actually. So fibrate affect these kind of disorder by supporting this primary therapy. Indications are hypercholesterolemia, maybe it is in case of heterozygous familial hypercholesterolemia, mixed dyslipidemia, hypertriglyceridemia, and as I told you, this fibrate should not be used in children and pregnancy, because this gemfibrozil crosses the placental barrier. Usually these fibrates are well tolerated drug, quite commonly used in practice. If you see after statins, these are the most commonly used prescribed drugs, and but side effect occurs, especially the GI side occurs in 5% of the patients, and they can also increase transaminases and alkaline phosphatase. Minor increase in may be there, but in case there is severe toxicity, then in that case you will see that there would be increase in these enzymes, as well decrease in albumin, as well as significant decrease in LDL and triglyceride, so that you can find out by LFT and all that. And myopathy, I discussed with all those along with statins also. This gemfibrozil has a high tendency to cause myopathy if used with statins, especially higher doses. That is why it is said that if you use statins with either this gemfibrozil, nicotinic acid, you should not use more than 25% of the maximal dose of these statins. So that is why if you use higher doses with gemfibrozil, chances of myopathy increases. And gemfibrozil is most notorious among all fabric acid derivatives. This complication is less with fenofibrate or other fabric acid derivatives, other fibrates, but this gemfibrozil, because it blocks OATP 1B1, which is important for extraction, hepatic extraction of these statins, first pass extraction, and it also interferes with glucuronide transfer conjugation of these drugs. So they can, because of the inhibition of both the pathways, this statins serum concentration may be doubled nearly by this. And any drug which increases the serum concentration with statins or higher doses are being used, that increases the propensity to cause this myopathy. And as I said, they are excreted by as conjugates in the urine through kidney. So the caution should be exercised if more than creatinine, serum creatinine level is more than 2 mg/%, and there is severe renal impairment, contraindicated, and hepatic impairment also, because they can cause hepatic toxicity, so contraindicated. But fibrates, especially this clofibrate, most commonly the clofibrate, it has can affect the action of warfarin, and it may increase bleeding tendencies even, and you may have to modify warfarin doses even, because this clofibrate and other fibrates may have anticoagulant effect and as well as antifibrinolytic effect. So they can all increase bleeding tendency from the warfarin, along with warfarin if used with warfarin. So they have an antithrombotic effect, these fibrates etc., but they can increase bleeding tendency. So the doses of the warfarin may have to be modified. So this is about these three classes of drug: fabric acid derivatives, bile acid sequestrants, and nicotinic acid. So rest of the things we will discuss in next class. So that should be the last part of this lecture, because I want everything to be conveyed to you in a understandable manner. So because this topic is difficult to understand actually, drugs you can mug up everything, but unless you know this lipoprotein metabolism and how exactly these drugs are doing, then you will remember this. And in your clinical practice also, once you got these things in your mind, you will remember this. Or if you just simply revise it, you will just refresh, can recall everything what has been taught to you. So again guys, this is to remind you that have this Telegram app, so that you can be made member, or you can join this group, which is is a medium to get information about the classes and all that, because this group is created by Unacademy, and we all educator and Unacademy people keep sharing the class information, timings, etc., schedule, etc., on this particular group. So you can have all the information right well in advance, and by clicking this link you can reach to directly to this YouTube NEET PG live channel. So if you have not downloaded it, please download it. And other than that, as guys, if you are aware, you must be aware, because time and again I am reminding you. So if you want to attend special classes of mine, if you really like my teaching, you come to this platform. I am talking about antibiotics there, clinical pharmacology of antibiotic use. One part has been covered, then second part I will be taking tomorrow, so at 6 o'clock. So please, if you want to come over there, just come and attend that class. And these classes are also free, but you will have a different experience on this portal. Especially its interface is really different, and you will have an opportunity, if you feel like, you can communicate with me through live chat. That will be visible to me. If you raise any question, any query, that will be immediately available to me. So first of all, you download it if you do not have this app, or ask your friends or other people. Spread this information to all, so that everybody can take benefit of these free classes. But for those who are not satisfied with these only free classes, want something extra, for them we have on this Unacademy platform the NEET PG Plus program, which is available on subscription basis. So for that, subscription period varies from 12 months to 24 months, and the minimum period you can subscribe for is 12 months. And so this is necessary. This much period is required for you to understand things, to get acquainted with the all the educators and the course material and the teaching, all that. So this is really important to have at least subscription for 12 months. And once you use this referral code, you will get 10% discount as well. So the subscription amount roughly is 20,000 for 12 months and 25,000 for 24 months. So I don't think it's a big deal. You can always subscribe and can come on this platform. Once again, I'm reiterating or emphasizing on the use of this referral code of mine, because this will give me a kind of appreciation from and this improves my ranking as well on Unacademy platform. So this is a request from you to use this. Once you have decided to join this NEET PG Plus, can use this referral code. And these are the facilities which are available on this NEET PG Plus platform, which are not available elsewhere. That is why it is considered as unique platform, and that's why it is available on paid basis. So but the facilities it is providing, I think it is worth subscribing to this channel, and definitely it will help in scoring better in your exams and all that. And you should not leave any opportunity unexplored, because if you get clear the exam in the very first attempt, it will save your 1 year almost. So that if you calculate that, so that will be more cost effective than just saving this 20,000 rupees, not attending these I don't say that once you subscribe you will definitely get or clear the PG exams. Your mehnat is 100% is required, but definitely chances or probability of selection increases, that I can tell you. So this is all about this academic subscription. So you guys are attending on YouTube, not my classes. You must be attending other classes as well. So keep attending on this NEET PG live daily and on YouTube, or absolutely free. Subscribe to this channel and tell to others also. And if you have liked my this class, just give me a thumbs up, so that you have this onus also to boost our morale also, so that we come up with better and better content, more informative content, and everything that you actually like. So share the link of this portal with your friends if they do not know about it. So keep watching and keep learning. That should be your goal, and this is our also aim to disseminate knowledge to all in a democratic way. So with this I say goodbye and good night, and thank you very much for attending the class.